You are standing in a crowded room, completely safe, when your body suddenly prepares for a lethal threat. Over the next 10 minutes, an invisible, crushing weight bears down on your chest, peaking in intensity before slowly resolving over the next half hour. The physical symptoms are acute and terrifying. Your heart races out of control. You cannot catch your breath. The room spins in a blur, and a profound, inescapable sense of impending death washes over you. Faced with these severe physical reactions, massive numbers of people rush straight to the emergency room, absolutely convinced they are having a massive heart attack. They are monitored, tested, and ultimately given a negative cardiac workup. Their heart is perfectly fine. Chest pain, shortness of breath, and dizziness, those physical sensations are completely real and overwhelming, but the medical emergency driving them is a biological false alarm. Experiencing a single false alarm like this is actually quite common. But having one panic attack does not automatically mean a person has panic disorder. To make that diagnosis, clinicians look for a specific pattern. This timeline graph shows the exact threshold. It requires a catalyst attack, followed by at least 1 full month of persistent, debilitating worry about when the next strike will happen. If we look at the demographic breakdown, this condition affects roughly 2 to 3% of U.S. adults annually. It typically surfaces in late adolescence or early adulthood, and women develop it at twice the rate of men. To prevent future attacks, people naturally start avoiding the places where previous episodes happened. A crowded grocery store, a busy highway, or a packed theater becomes a threat. About half of the people diagnosed eventually develop agoraphobia, severely restricting where they can go. The 10 minutes of physical panic are brutal, but the true paralyzing force of the disorder is the chronic fear of fear. It creates a behavioral vacuum that progressively shrinks a person's entire world. The first step in treatment is dismantling the immediate, terrifying myths surrounding those 10 minutes. You are not having a heart attack. The symptoms do not cause psychosis, and you are not losing your mind. This biological feedback loop shows what is happening. A normal physical sensation, like a slight increase in heart rate, travels to the brain's threat assessment node, which erroneously flags it as a lethal danger. The brain misinterprets safe bodily data. This presents a clinical challenge. How does medicine stop a condition where the brain holds the body hostage based on a misreading of normal sensations? Because the disorder is a learned misinterpretation of the body, relying purely on avoidance or temporary distraction fails. The only permanent solution involves intentionally retraining the brain's baseline threat response. The first-line evidence-based treatment achieves exactly this through a highly effective, albeit counterintuitive approach: cognitive behavioral therapy paired with interoceptive exposure. Instead of avoiding symptoms, this staircase visualizes how therapists guide patients to deliberately trigger physical panic sensations. They step up the intensity in a safe, graduated way, while the safety indicator holds steady. A therapist might ask a patient to spin around in a chair to induce severe dizziness, or breathe through a thin straw to simulate shortness of breath. After 12 to 15 sessions of these exercises, the feedback loop changes. The brain experiences the racing heart and the dizziness, and finally registers a secure, safe signal. It learns that these physical sensations are deeply uncomfortable, but entirely harmless. While FDA-approved SSRI medications can support this process, benzodiazepines are typically avoided. They actively suppress the very physical symptoms the patient needs to feel in order to complete the exposure work. The cycle of fear and avoidance is broken specifically by deliberately inducing and facing the physical symptoms head-on. The clinical treatment proves that the brain can relearn safety, but panic disorder rarely confines its terror to a doctor's office. It creates intense fear tied to specific everyday locations in a person's life. Retraining the brain's threat response reaches its highest efficacy through in vivo exposure, meaning the exercises are practiced in the actual physical environments where the panic attacks historically happen. This is where modern telehealth provides a distinct clinical advantage. Patients no longer have to endure a terrifying commute to a distant clinic. They can execute this exposure therapy alongside a licensed professional directly from their own living rooms, cars, or offices. Telehealth takes a patient's geographic isolation and agoraphobia, previously a debilitating symptom, and turns it into a strategic advantage for targeted, in-context treatment. For residents across all 159 counties in Georgia, Coping and Healing Counseling provides this dedicated, 100% HIPAA-compliant telehealth solution. They eliminate the standard friction of seeking mental health care by offering same-week scheduling with a diverse, culturally competent team of over 15 licensed therapists. Looking at this cost breakdown chart, CHC prioritizes strict financial accessibility. Medicaid requires a $0 copay, and commercial insurance plans typically range from just $10 to $40 per session. Panic disorder makes you feel like you are dying or losing your mind, leaving you trapped in a cycle of avoidance. But with accessible, evidence-based care available right now at chctherapy.com, you do not have to navigate it alone.